Hi, my name is Gustavo Vinagre and I'm here to talk to you about meniscal injury. The internal meniscus has an attachment to the internal lateral ligament and the posterior oblique ligament. There is a decreased mobility in the body and posterior horn, and due to that, there is an increased risk of rupture. And the external meniscus is more lax. It has no capsular insertion on the popliteus. There is an increase on the mobility, and there is a decrease of risk of fracture. As you can see here, the lateral meniscus is much more mobile. So you have the medial meniscus and the lateral meniscus. As you can see, the medial meniscus has a C shape and the lateral meniscus has a no shape. The C shape of the medial meniscus and the O shape of the lateral meniscus. As you can see here, there is an anterior meniscal femoral ligament and a posterior meniscofemoral ligament. One is anterior to the PCL and the other posterior to the PCL. So when you have a PCL tear, they both can avoid the posterior draw of the knee. So here you can see the different fibers of the meniscus, and there the meniscus is vascularized much more on the peripheral zone. As you can see, there is a red zone, the red-white zone, and the white zone without no vascularization. And in the Arnowski image, you can see how the vessels came into the meniscus. There are different functions of the meniscus. It is a spacer to prevent the contact between article surfaces. It is a load-bearing structure where it increases the contact area, especially on the lateral meniscus, and it reduces the contact stress. So it can increase the contact pressure, and it is a joint stability. It gives joint stability. It absorbs the shocks of the knee, and it can assist in overall lubrication of the articular surfaces. It transforms the compression forces into radial forces. So there can be different types of meniscal tears. There can be a vertical longitudinal tear. It can be a horizontal tear, and there it can be a bucket handle tear. And that kind of tears can evolve into different types of tears. You can see here how a longitudinal tear can be displaced into a bucket handle tear and block the knee. So you should think of the meniscus tear into by an intact ACL, a torn ACL, or in the lateral side or in the medial side. And you can treat it with different options for hours: to retain, to do nothing, to repair it and to pass some sutures into the meniscus, to resect or do a meniscectomy, or to replace it either with allograft or with a scaffold. You can repair it with different techniques, the open technique and the arthroscopical technique. You can do it inside out, outside in, or all inside the knee. So if you want to suture the anterior horn of the meniscus, you should do an outside in technique, because it's the only one you can do. If you want to do an inside out technique, you should do it on the posterior horn or in the mid horn, but you shouldn't do on the posterior horn of the lateral meniscus. And you can do an all inside technique either on the mid side of the mid horn or the posterior horn. You can repair it with different surgical devices. You can suture it with different sutures. You can use staples, you can use arrows, you can use darts, and new devices as we are going to see next. So in the inside out technique, you use flexible needles and you knot the ties outside the joint over the capsule, You can do it on the medial horn of both menisci and the posterior horn of the medial meniscus. You have a neurovascular risk of some complications. In the medial side, you have the saphenous nerve and vein, and in the lateral side, you have the peroneal nerve and popliteal artery risk. So the outside-in technique, you can grab the meniscus with two spinal needles, and you pass one suture and retrieve it in the other side. So you do an outside-in technique, as you can see here, and you knot the tie out, and you knot the tie outside the capsule. You can do an all-inside technique. You can see these devices, the meniscal cinch, and you use it on the medial and the posterior horns of both menisci. If you use the ConMed devices, you can do a continuous suture, as you can see here, and you can use some devices with all basic with suture only, as the Ceterex. There is no plastic, so you can repair different types of tears. And you can use this type of devices where there is an retrieving mechanism, as this first pass device. And which is the ideal patient to suture? Is a young age patient with lateral meniscus, a stable knee, an associated ACL reconstruction, a peripheral vascularized zone, either red zone or red-white zone. There should be a recent tear, and you should use a vertical thick suture. As you can see here, it's much more stable than the horizontal. So, as Verdon teaches you, either you think to repair a meniscus or do a meniscectomy. You should know that the meniscal repair has an increase in operation rates, much more. So it has a better outcome than meniscectomy in long term, and it has a better outcome with ACL reconstruction or in the lateral meniscus. By the other side, the meniscectomy decreased the operation rate. It has more osteoarthritis progress than a meniscal repair, but it is an early recover and a less return to play period. So if you think about the lateral meniscus, you should think about you should consider to repair it, especially in young patients. And if you consider a medial meniscus, you should resect it, unless that it is on the red zone. So let's move on to the meniscal root tear. There are some meniscal roots. There are 4 meniscal roots, as you can see here. There is the attachment of the meniscus into the tibia, as you can see here. So sometimes you have some tears, and if you have a tear of the meniscal root of the meniscal tibial ligament, it is like having a total meniscectomy, as the meniscus is not functioning as a load-bearing structure. So there is sometimes some types of classifications, as you see here from the Laprade group. And how to diagnose a meniscal root repair? If you see a ghost sign on the MRI, as you can see here, there is no attachment to the meniscal tibial ligament, and on the sagittal plane, you don't see the posterior horn of the meniscus, and you see the anterior horn of the meniscus. So there is the ghost sign and a sign of a meniscal root tear. Don't confound to the ghost meniscus. When you see on the coronal plane, you don't see the meniscus, so it is indicative of a radial tear. Okay. So how do you fix the posterior meniscal root tear? With a transtibial double bundle pull-out technique, when you do 2 tunnels on the tibia, and you suture, you pass the sutures, and you put a button on the front, or you can use a single tunnel with an ACL tibial guide. So let's see the indications to the meniscal transplant. When you should do a meniscal transplant, when you have an isolated lateral or medial pain, after a total meniscectomy or a meniscectomized knee. So it's much more frequent on the lateral side. And the contraindications are open physis, unstable knee, malalignment, varus or valgal stress, degenerative changes, bipolar cartilage lesions, or obesity. In the lateral meniscus, you should do a bone bridge technique, not on the medial side because of the ACL footprint. And you should do like this bone block with an oscillating saw or with a rasp, as you can see here. So on the medial side, you can do a double bone plug technique or only use some sutures on the anterior and posterior horn of the meniscus. And you should do a 9 millimeters bone tunnel. You can do it with 2 tunnels or with 3 tunnels technique, okay? And you should do it, the tunnels on the contralateral side of the meniscus, as you can see here. And you put the allograft inside, you pass some sutures to the allograft, and then you should do an inside out technique to fix it to the capsule. What are the meniscal scaffolds? Meniscal scaffolds are a collagen type 1 bovine structure where there are some colonization of this scaffold, some natural colonization. So when we should do it? When you have a young patient skeletally mature with an acute or chronic irreparable meniscal tear with a meniscal loss more than 25%, and the defect length should be limited to 5 to 6 centimeters and should be an intact meniscal rim and in an aligned knee joint. The contraindications are ligament instability, axial malalignment, BMI higher than 35, a full thickness loss of article cartilage, ECRS higher than 3, and a meniscal root lesions or knee osteonecrosis, or an infection or and some inflammatory diseases. So you should measure all the meniscal defect, and then you should cut your meniscal scaffold and put inside and grab it with an inside out technique and put some stitches on it. So these were the references I used to this talk. I hope you like it, and don't forget to save the meniscus. So see you on the next talk, and bye.